Thank you for attending my session today. My name is Teresa Wang. I'm a pediatric anesthesiologist at Boston Children's Hospital at Harvard Medical School. Today, we will be talking about pediatric acute life support, or PALS for short. To begin with, I have no disclosures to make. Our objectives today will be to start with reviewing pediatric single provider basic life support. We'll then move on to reviewing pediatric two provider basic life support. And then finally move on to review pediatric acute life support, PALS, with an emphasis on the following algorithms: bradycardia, tachycardia, cardiac arrest, opioid-related resuscitation, as well as extracorporeal cardiopulmonary resuscitation, ECMO or ECPR in this case. Our basic principles of resuscitation are as follow. For lay rescuers, you should begin CPR for any victim who is unresponsive, not breathing normally, and has no signs of life. Do not wait to check a pulse. This does not mean that we do not check a pulse, simply means for the lay rescuer that CPR should progress immediately. And for healthcare professionals who are actually more skilled at checking pulses, the pulse should still be checked. However, limit the time to less than 10 seconds. The sequence of resuscitation is still CAB, which means compression, airway, and breathing. This is the same for both adult as well as pediatric resuscitation. And the mainstay of resuscitation obviously is still high quality CPR, and to initiate it as soon as possible. The main components of high quality CPR are as follow. 1, adequate chest compression depth. This means about 1.5 centimeters in infants, and those are children less than 1 year of age, or 2 centimeters in a child, which is defined as between 1 year of age until puberty. Or generally, as a rule of thumb, give compressions 1/3 the depth of the patient's chest. Optimal chest compression rate is 100 to 120 per minute. Minimize any disruption in CPR, maximizing the chest compression fraction or the proportion of time that chest compressions are provided for optimal resuscitation. Allow for full chest recoil between compressions to allow the ventricles to fill, and avoid excessive ventilation, as this can insufflate the stomach and increase the risk of aspiration. For patients who are post-puberty, generally adult compression guidelines are used. The most basic form of resuscitation begins with basic life support with a single provider. As for any victim, always call for help immediately and activate the emergency response system as soon as a victim is identified. Begin with checking the breathing and the pulse. If a patient is breathing normally and a pulse check reveals that a heart rate is greater than 60, then begin rescue breathing with pulse checks every 2 minutes. If at any time the heart rate is identified to be less than 60 beats a minute, begin CPR immediately. With one rescuer BLS, the rate of compressions to breaths is 30 compressions to 2 breaths. During rescue breathing, give a head tilt and a chin lift to open the airway. Watch for chest rise as a guide for the pressure applied to insufflate the lungs, and also to avoid excessive high pressure breathing, which can distend the stomach and increase the aspiration risk. As soon as help arrives or an AED becomes available, attach the defibrillator, and if a shockable rhythm is identified, immediately shock as soon as CPR. Then begin CPR immediately without delay. For an infant BLS single provider resuscitation, using the 2 fingers below the intermammary line to provide chest compressions, as the photo demonstrates, is an acceptable method to provide chest compressions. In the basic life support 2 provider algorithm, the sequence for checking for responsiveness, pulse, and breathing remains unchanged. While one rescuer remains with the patient to provide basic life support, the second rescuer should leave to get help and a defibrillator. Begin 1-person BLS with 30 compressions to 2 breaths until the second rescuer arrives. The same rules apply for chest compression depth, rate, as well as the rescue breathing guidelines. Once a second rescuer returns with the defibrillator, attach a defibrillator to the victim immediately without interrupting compressions or rescue breathing. Once the defibrillator is attached, perform a rhythm check, and if the rhythm is shockable, charge and deliver a shock as soon as possible, then resume chest compressions without delay. At this point, proceed to the 2 rescuer BLS resuscitation guidelines, with the only change being the CPR compression to breathing rate. There should now be 15 compressions to 2 breaths, switching compressors every 2 minutes. With 2 providers, generally speaking, the 2 thumbs encircling the chest is the best method and advised method for CPR on an infant, as the image shows. Now, before discussing pediatric acute life support, we must review the role of advanced airways in pediatric resuscitation. Most pediatric arrests are actually airway-related, and this is actually rather different from adult cardiac arrest events, which are most often of cardiac in origin. Previously, as some of you may remember, the recommendation was to focus on airway first and then compressions. However, studies have shown that can lead to significant delays in the initiation of high-quality CPR, which can affect resuscitation outcomes negatively. As such, the newer guidelines stress beginning with high-quality chest compressions. That isn't to say that checking for airway breathing and supporting breathing is not important, but merely not to delay compressions for excessively long periods of time in order to check for breathing. In all cardiac arrests, whether it is children or adults, establishing an airway and placement of an advanced airway is still instrumental to successful resuscitation outcomes. Advanced airways like supraglottic devices, such as laryngeal mask airways or LMAs for short, or endotracheal tubes or ET tubes, may help improve ventilation, reduce aspiration, and improve uninterrupted compression delivery. When there's an advanced airway in place, the guidelines for pediatric acute life support is to give 20 to 30 breaths a minute. But the key is still to not place an advanced airway at the cost of chest compressions. If equipment's not available or adequately trained personnel are not available, proceed with bag mask ventilation in those instances until experience or equipment arrives for placement of advanced airways. The first algorithm we're going to review in the pediatric acute life support series is bradycardia. Assess the patient, and bradycardia is defined as heart rate less than 60 beats per minute. If the patient has no signs of cardiopulmonary compromise, such as altered mental status, signs of shock, or hypotension, care is mostly supportive, provide supplemental oxygen, obtain a 12-lead EKG, and treat underlying causes such as hypothermia, hypoxia, or medications. If, however, the patient has been determined to have cardiopulmonary compromise, such as altered mental status, shock, or hypotension, or if the heart rate is less than 60 beats per minute, begin chest compressions immediately. Obtain IV access or IVO access if IV access is not available. At this point, epinephrine at a dose of 0.01 milligrams per kilogram should be given every 5 minutes. If increased vagal tone is suspected to be the cause, or if a primary AV block is suspected to be the cause of the bradycardic event, atropine may be given at a dose of 0.02 milligrams per kilogram. And if all of the above measures fail, consider pacing, whether that is transthoracic or transvenous, and expert consult. For patients who have tachycardia, maintain an adequate airway, assess the patient, provide supplemental oxygenation if needed, and obtain a 12-lead EKG to better identify the rhythm. Once again, assess for whether or not there are signs of cardiopulmonary compromise. If there are no signs of altered mental status, shock, or hypotension, analyze the EKG rhythm. If the rhythm is narrow complex, this could be possible supraventricular tachycardia or SVT. At this point, if the patient's stable, you can consider vagal maneuvers such as carotid massage or sprinkling ice over the face, or giving IV adenosine. The doses should be initially 0.1 milligrams per kilogram. If a second dose is needed, escalation to 0.2 milligrams per kilogram is appropriate, with a max of a 12 milligram per kilogram rapid bolus. If the complex determined is not narrow complex, but wide complex, regular, and monomorphic, the rhythm could possibly be ventricular tachycardia. Treatment would still be to consider adenosine and also obtain expert consult as long as the patient remains hemodynamically stable without signs of acute compromise. However, if the patient has a tachycardia rhythm and you have identified that there are existing signs of cardiopulmonary compromise, such as altered mental status, hypotension, hemodynamic instability, and the 12-lead EKG reveals a narrow complex, this may be symptomatic supraventricular tachycardia. Treatment could be with either adenosine at 0.1 milligrams per kilogram, escalating to 0.2 milligrams with a max of 12 milligram per kilogram push, or if the patient is very symptomatic with severe signs of hypotension, synchronized cardioversion is also an option. The dose should be 0.5 to 1 joule per kilo, up to a maximum of 2 joules per kilo, and consider sedation for the patient if the patient is awake. However, do not delay cardioversion in the setting of hemodynamic compromise just to give sedation. If the cause of the tachycardia is wide complex but regular and monomorphic, consider treatment with synchronized cardioversion at the joules mentioned before, and also obtain expert cardiology consult for additional recommendations. Moving on to full cardiac arrest under the pediatric acute life support algorithms. Once arrival at the scene and a patient is identified to be in full cardiac arrest, begin CPR immediately without delay. Start ventilation at a rate of 15 compressions to 2 breaths via masking. And if an advanced airway is in place or able to be established, give rescue breathing every 2 to 3 seconds, And as soon as an AED is available, please attach the pads to the patient and identify the rhythm. If the patient's rhythm is identified to be a shockable rhythm, meaning it is either ventricular fibrillation or pulseless ventricular tachycardia, a shock should be delivered immediately without delay. Begin at 2 joules per kilo, with subsequent shocks escalating to 4 joules per kilo for the second, with a max of 10 joules per kilo for subsequent shocks. After delivering a shock, begin chest compressions without delay for 2 minutes until the next rhythm check. At the next rhythm check, determine whether or not the rhythm is still shockable. If so, deliver a second shock at an escalated dose of joule per kilo. And at this point, it is advisable to give IV epinephrine at a dose of 0.01 milligrams per kilogram and continue to give epinephrine every Q3 to 5 minutes. After the shock, resume chest compressions without delay until 2 minutes later at the next rhythm check. If the rhythm determined at this point is still shockable, deliver a shock, and at this point, you can consider giving one of 2 antiarrhythmics. Amiodarone at 5 milligrams per kilogram bolus can be given up to 3 doses, or lidocaine at a 1 milligram per kilogram loading dose. It is useful to time epinephrine administration as well as antiarrhythmic administration to rhythm checks. Remember that every other rhythm check should be given either epinephrine or an antiarrhythmic, that is lidocaine or amiodarone. That way, the dosages of each is Q4 minutes and falls within the Q3 to 5 minute resuscitation guideline. And as always, treat any underlying cause of the arrest if it can be identified during the resuscitation attempt. For cardiac arrest with a rhythm that is not shockable, begin CPR without delay as previously mentioned. Continue the ventilation at 15 compressions to 2 breaths, and also give the first dose of epinephrine as soon as it is determined that the rhythm is not shockable. Continue CPR for 2 minutes with rhythm checks every 2 minutes, and also treat the underlying causes of either the asystole or pulseless electrical activity. The 5 H's and T's that are frequently underlying causes include hypovolemia, hypoxemia, hydrogen ions or acidosis, hypoglycemia, hypo or hyperkalemia, as well as hypothermia. The T's include tension pneumothorax, tamponade, cardiac tamponade, toxins, thrombosis of either the pulmonary or thrombosis of the coronary circulations. Once you have return of spontaneous circulation, remember the work is not done. Post-cardiac arrest care is pivotal to good long-term outcomes. In the post-cardiac arrest care algorithms, oxygenation should be targeted and monitored to maintain a saturation of 94 to 99% with maintenance of normal capnia. Temperature can be slightly cooled at 32 to 34 degrees Celsius with return to normal to 36 to 37.5 degrees Celsius, or maintain normal at 36 to 37.5 degrees Celsius. The key here is to avoid fever. Neuromonitoring should be used if you're in a facility that can provide continuous EEG monitoring. If seizures are identified, anti-epileptic medications should be begun to treat the seizures. Frequent electrolyte and glucose checks should also be instituted with care to avoid hypoglycemia and electrolyte disturbances, which can increase the risk of arrhythmias. Sedation should also be given to any patient to make sure that they are comfortable. Given the opioid epidemic, pediatric patients are also sometimes affected. The new 2020 guidelines also provide recommendations for how to manage opioid-related overdoses and resuscitation for pediatric patients. And the sequence of events are as follows. As always, identification of a victim and early activation of the emergency response system should begin. If a patient is not breathing and is determined to be in respiratory arrest, begin assisting with rescue breaths immediately. If the patient is in full cardiac arrest, begin CPR and the PALS cardiac arrest algorithm immediately. The key is not to delay any treatment, whether it's rescue breathing or full cardiac arrest and CPR algorithms, to administer naloxone. If suspected opioid overdose is at play and naloxone becomes available, give the naloxone as soon as possible and proceed with resuscitation efforts. The reason for this is because the cause of the arrest can be multifactorial and may not be solely related to opioid overdose. As such, during the resuscitation attempt, we do not want to miss any other reasons for the cardiac arrest. Extracorporeal cardiopulmonary resuscitation using ECMO or ECPR is becoming frequently more common. For any patient who has no return of spontaneous circulation, consider VA ECMO for ongoing resuscitation. Rapid deployment of veno-arterial ECMO for patients who do not achieve sustained return of spontaneous circulation is a very resource-intense, complex, and multidisciplinary therapy, and traditionally has been limited to large pediatric medical centers with providers who have expertise in the management of these patients. However, judicious use of ECPR for specific patient populations and within dedicated and highly practiced environments has proved successful, especially for in-hospital cardiac arrests with reversible causes. ECPR use has increased, with single-center reports in both the adult and pediatric populations, suggesting the application of this therapy across broader patient populations may improve survival after cardiac arrest. As such, using ECPR as a modality should be in the back of everyone's minds moving forward. In summary, here are some of the takeaway points. High-quality cardiopulmonary resuscitation is the foundation of resuscitation. New data reaffirms the key components of high-quality CPR, which includes providing for adequate chest compression rate at 100 to 120 beats per minute, depth, which is 1/3 the chest, minimizing interruptions in CPR, allowing for full chest recoil between compressions, and avoiding excessive ventilation. Respiratory breaths at a rate of 20 to 30 per minute for infants and children with an advanced airway can improve resuscitation outcomes. For patients with non-shockable rhythms, the earlier epinephrine is administered after initiation of CPR, the more likely the patient is to survive. Using a cuffed endotracheal tube decreases the need for endotracheal tube exchange later on during resuscitation. The routine use of cricoid pressure does not reduce the risk of regurgitation during bag mask ventilation and may actually distort the airway and impede intubation success. For out-of-hospital cardiac arrest, bag mask ventilation results in the same resuscitation outcomes as advanced airway interventions, such as using endotracheal intubation. Resuscitation does not end with return of spontaneous circulation. Excellent post-cardiac arrest care is critically important to achieving the best patient outcomes. For children who do not regain consciousness after return of spontaneous circulation, this care includes targeted temperature management, continuous EEG monitoring, prevention and treatment of hypotension, hypoxia or hyperoxia, as well as hypercapnia or hypocapnia, all of which are equally important. After discharge from the hospital, cardiac arrest survivors can have physical, cognitive, as well as emotional challenges that may need ongoing therapies and interventions. And finally, naloxone can reverse respiratory arrest due to opioid overdose, but there is no evidence that it alone benefits patients in cardiac arrest, and full cardiac arrest algorithm management should proceed despite suspicion that it is an opioid-related overdose in order to avoid missing other causes for the cardiac arrest. Thank you very much for listening to this lecture. If you have any questions, please feel free to bring them up.